Good morning, North America. Good afternoon, Brazil and Europe. Good evening. On behalf of the Radiologia Society of Rio de Janeiro, I want to welcome and thank everyone for tuning in today for the MSK case presentation series. My name is Aline Serfari, and I'm here today with Dr. Hilary Humans, who coordinates this series with me, and with our guest speakers, Dr. Jana Crain, Dr. Patrícia Martins, Dr. Kate Stevens, and Dr. Atul Taneja. Before we begin, I want to let you know that the presentations today, like all the previous ones, will be recorded and will be available on demand on the OCAD website and on the YouTube channel of the Radiologia Society of Rio de Janeiro. To have access to all the presentations of this series and also to the lectures of the OCAD's multidisciplinary series, all you have to do is register to the OCAD website, which is ocadmsk.com. And in case you want to learn everything that will take place in the following weeks, you can follow OCAD on Twitter and the Radiologia Society of Rio de Janeiro on Instagram. Back to our presentations. The speakers today will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them on in the chat box, and at the end, the speakers will respond to them. And as I always say, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you so much for your understanding, and without further ado, I will ask Hilary to introduce our first speaker today.
Hi, good day. It's my pleasure to introduce Dr. Jana Crain. She completed her medical training and residency at the University of Arkansas and musculoskeletal fellowship at the National Orthopedic Institute in San Francisco, which is where she currently works. She's published extensively on wide-ranging topics in sports imaging and is a consultant for several professional sports teams in Major League Baseball and the National Football League and collegiate teams, as well as the U.S. ski and snowboard team. She's a sought-after authority in sports imaging, and I look forward to her case presentation. Okay, Janice, go ahead and share your screen.
Thank you so much, and obrigado and bom dia. It's an honor to be invited and be a part of your team this morning for me and this afternoon for you. And above all, I just want to say thank you for giving me this chance to learn from you guys as well. So yeah, I hope to have something interesting to share with you and to learn from all of you. Yeah, as she said, I'm based in San Francisco, and in addition to reading cases for the 49ers, we just dealing with team doctors all over the country. We just get a lot of football players that are getting second opinions from doctors that I work with as well. And this happened to be a professional football player that was in his early 30s who presented with severe pain 6 weeks after a deltoid ligament repair, and just was having increase in swelling, and the history was just evaluate synovitis, loose body. He had actually had his surgery out of state, and so he came back to California and was just seeing an orthopedic surgeon that I was working with. And one of my partners, one of my esteemed colleagues, read the case. There's as my partner noted, there was obvious mass in the anterior recess of the tibia-talar joint. You can see the periarticular disuse osteopenia around the tibia-talar joint as well, and even a little bit of micrometallic artifact here on the edge from the deltoid ligament repair. And just a couple more planes, again, the anchor artifact from the deltoid repair and the overlying micrometallic artifact, as well as the mass within the anterior recess of the tibia-talar joint. And so the doc actually, I was home for Christmas on vacation, and the doc actually called and said, hey, do you think this can be a pseudoaneurysm? And I said, wow, I've never seen that, but let me take a look. And I was on my laptop and I was not able to scroll through it. Sorry. I'm going to see if this video works. It's going to take a minute. You can see the flow void of the posterior tibial artery, but just the slow flow of the vessels anteriorly that are just draped and smashed on the surface of this mass. And as they go medially, just a little distal, you can see where the dorsalis pedis, a little bit of high flow in the artery is picking up here at the end. And so I said, well, at this point, it's pseudoaneurysm and still until proven otherwise, let's get an ultrasound. And actually the ultrasound was not conclusive. And so we ended up going to surgery, and it was a pseudoaneurysm, and they just ligated, it's right at the junction of the anterior tibial artery becoming the dorsalis pedis. And so then ironically, just within a year later, this was a middle-aged woman who had played basketball and attributed her ankle instability to playing basketball most of her life. And she also presented, not immediately post-op, but within 2 months after post-op, with severe pain, swelling, limited motion. And so neither history was evaluate pseudoaneurysm, and ironically, this is not reported in the radiology literature at all. But here we see, this heterogeneous mass, but that classic swirl appearance. But if it was more dominantly black, it could be fooled by just being a hematoma post-op, or even a calcified mass, as one was called. And, a lot of times, the post-op patients, they get that shaving of the anterior plafond spur as well. And here you can see the mass in the anterior recess. And then on axial images, just right above that, on this case, it was really obvious. You just had this nice flow void of the anterior tibial artery, and it just dived right into this pseudoaneurysm. And so I just thought it was interesting to see the surgical side of it. And ironically, I got this information. There was a case report that wasn't of a pseudoaneurysm, but was of embolic phenomena of necrotic, ischemic first and second toes after an ankle arthroscopy. And ironically, the case report was out of the Sociedade Campinas, Brazil. And so thank you to your Brazilian compadres that gave me this information as well. But, just for ankle arthroscopy, there's, anywhere from less than 1% to 17% complication rate. And the more common ones that we can see post-op is, rule out infection or fistula or even CRPS or secondary fracture. But neurovascular bundle and tendon injury account for about 3 to 9% of injuries. And ironically, in both of these cases, they both had the extensor digitorum brevis denervation edema, indicating some nerve injury, some traction there. Although that's not an uncommon finding to see that nerve knocked out, and it doesn't end up being clinically significant, but just a sign that there was neurovascular bundle stretch. And it also described the superficial perineal nerve injury as being more common, and that it tends to resolve in the post-op period. And although this is a less common injury, I thought it was just important to note, because when you see it, the patient goes straight to surgery. And just of note, just with any plantar flexion and traction, that really makes the neurovascular bundle taut and kind of decreases the space between the neurovascular bundle and the joint. But just with a little bit of dorsiflexion, that really relaxes the vessels and allows them to be mobile. And so even though you've got that scope right next to it, you have less damage to the cartilage and less damage to the bundle. But granted, when you're doing, ironically, both of these cases were ligament reconstruction cases, and probably just took maybe a little more force and wanted more traction, or to get in there and do what they needed to do. And just another thing that I'd never really thought to look for is just variations in the location of the artery, with a small percentage being a little more medial or a little more lateral, which could increase risk of having vascular complication if the surgeon wasn't aware of this. And just as one other complementary case, and especially for Brazil, you have so many baseball players, where America is the home of a ton of baseball, as well as Brazil. And this was an asymptomatic screening player in the minor leagues for the Cleveland Indians. And, most of the time we're just looking for internal impingement and how severe is the cuff tendinopathy, and making sure there's not a big unsuspecting cuff tear or denervation from a big paralabral cyst with a labral tear. And so the labrum and cuff looked fine. A lot of these guys are just kind of in and out with the screening or pre-signing period. But of note, just on one image on each of the sequences, you can see this vascular dilatation here along the posterior circumflex artery in the quadrilateral space anteriorly. And on the coronal image here, you can see the low flow of the artery with the high flow the low flow of the artery, high flow of the artery with the low signal, and the high signal, low flow surrounding it in the pseudoaneurysm. And this was incidental pseudoaneurysm of the posterior circumflex artery in a baseball player. But above all, I just wanted to emphasize, it's just nice to review, to always kind of go through your neurovascular bundle as part of your sequencing, of going through all your images of your kind of checklist or form, how you go through. And And in a post-op case, to be aware of that in the ankle, as well as to be aware asymptomatically in certain patients. And certainly it's easier to see things when the mind knows it could be there. And thank you very much. That's all I have.
Thank you very much, Jana. Beautiful case. We have the pleasure of having here Dr. Patrícia Martins join us today. She's a practicing musculoskeletal radiologist at Instituto Nacional de Traumatortopedia, INTO, and at Clínica Luiz Felipe Matoso, Fleury, here in Rio de Janeiro, where she is the section head of musculoskeletal imaging. She's very involved in MSK education, having created the mskrad.com.br, where you can find excellent MSK content. We are delighted to have her here today.
Okay, thank you, Aline Serfati, for the invitation and the OCAD community for this opportunity. It's a pleasure to be here. I have no disclosures. Today, I'm going to talk about a case of a 24-year-old male professional volleyball player reporting pain in the posterior aspect of the glenohumeral joint during throwing and sometimes at rest. But before we jump into the case, I would like to fill you in on some of the background relating to overhead sports. One thing these sports have in common is the risk of internal impingement of the shoulder. This occurs during the cocky and early acceleration phase of throwing, when the shoulder is at maximal abduction and external rotation. In this position, the greater tuberosity abuts against the glenoid, entrapping the rotator cuff. These repetitive movements lead to increase the risk of pathological conditions in the dominant shoulder. This brings us back to the index case. In fact, the patient presents with these common abnormalities of internal impingement of the shoulder. In the coronal T2 fat suppressed MRI image, we can see enthesial chains in the greater tuberosity, subacromial subdeltoid bursites. In this coronal T2 fat suppressed MRI images, we can see enthesial chains in the greater tuberosity, subacromial subdeltoid bursites, a partial thickness articular side subspinatus tear, extending here greater than 50% of the footprint, and a slap lesion. Although these finds are commonly seen in all overhead sports, there are anomalies more specific to some sports like volleyball and tennis. Let's come back to the index case. Here in transversal T2 images with fat suppression, if you pay attention to the muscle bellies, we can see a severe infraspinatus atrophy with high signal in this fluid-sensitive sequence. Coronal images show diffuse muscle edema on T2, and infraspinatus muscle is atrophied and infiltrated with fat on T1. On sagittal plane, we can see the infraspinatus myotendinous junction and the atrophy and fat degeneration of the infraspinatus muscle. Here we can see the high signal and here the atrophied muscle. And we can compare with the other muscles in the shoulder of this patient. I don't have a picture of this patient, but according to his physician, it's similar to the case we can see in this article of the American Journal of Sports Medicine about the high prevalence of infraspinatus muscle atrophy among professional beach volleyball players, a shallow infraspinatus fossa in the dominant arm caused by atrophy of the infraspinatus muscle. Indeed, other players in the same volleyball team of the index case also presented with isolated infraspinatus muscle atrophy. The infraspinatus muscle of this 22-year-old male athlete has reduced volume and myoedema in this fluid-sensitive sequence, here in transversal and coronal plane, but doesn't have significant fat degeneration on T1, just few fibers. In sagittal plane of the same player, we can see increase the signal on T2 and the reduced volume of infraspinatus muscle on T1. This transversal and sagittal image of another athlete at the same team also show discrete edema and isolated infraspinatus muscle atrophy on T1. For this reason, some authors name it isolated infraspinatus muscle atrophy volleyball shoulder, since it's quite common among volleyball athletes, with reports of at least 33% incidence in high-level players. In Brazil, volleyball is the second most popular sport after soccer, being the most common overhead activity. And after Gustavo Kirten won the French Open in 1997, tennis became the second most common overhead sports in Brazil. Furthermore, we also can see infraspinatus muscle atrophy in professional tennis players. Indeed, two recent papers reported a rate of infraspinatus atrophy in male and female professional tennis players, over 50%. This is a greater incidence of infraspinatus muscle atrophy among high-level football players and tennis professional players when compared with other overhead sports like baseball, only in 4.9% of the pitches and 0.2% of the other positions. Some authors propose that the float serve is likely to be the cause of infraspinatus muscle atrophy, as it involves a very sharp ball impact to give the ball a floating trajectory. For the sharp impact to be achieved, the infraspinatus is intensely activated. The infraspinatus provides the premier muscle force for the external rotation of the shoulder and is innervated by the subscapular nerve. The subscapular nerve arises from the upper trunk of the brachial plexus, providing motor innervation to the supraspinatus and infraspinatus muscle. Along its course, the nerve is vulnerable at two anatomical locations, the subscapular notch and the sphenoglenoid notch. Several causative mechanisms have been proposed for the pathogenesis of infraspinatus atrophy in overhead athletes, and it's widely accepted that the position of abduction and external rotation during a cocking phase can result in physical compression of the subscapular nerve at the sphenoglenoid notch. A chronic traction at the sphenoglenoid notch due to eccentric infraspinatal contraction, the extremes of shoulder positions, or a kinking providing irritation of the nerve at the subscapular notch, or a combination of those mechanisms lead to cumulative tensile subscapular neuropraxia. Fortunately, infraspinatus muscle atrophy in overhead athletes is often clinically asymptomatic. However, weakness of the external rotators can be found. In addition to these mechanisms, it's important to consider some differential diagnoses. One of the most common is a compressive paralabral cyst as a cause of subscapular neuropathy. In this case, a 47-year-old male has a sphenoglenoid notch paralabral cyst causing compressive subscapular neuropathy with subtle signs of subscapular denervation. We can see in sagittal plane the paralabral cyst and a subtle increase of the signal of the infraspinatus muscle secondary to suprascapular denervation. Another important cause of infraspinatus muscle atrophy is brachial neuropathy, such as Parsonage-Turner syndrome. In this case of a 38-year-old male, we can see acute subscapular denervation with atrophy and edema-like signal of the supraspinatus and infraspinatus muscles. Other neuropathies with isolated muscle atrophy can occur in overhead athletes, such as isolated teres minor muscle atrophy, which occurs in nearly 6% of the shoulder MRI images. And the proposed mechanisms include traction injury to the axillary nerve. It's very important to recognize this finding in overhead athletes, since when there is infraspinatus muscle atrophy, teres minor muscle performs dysfunction. So, points to take home. We need to be careful with search satisfaction. Not all overhead athletes will suffer from only anomalies relating to internal impingement of the shoulder. Each activity has some particularities, and volleyball and tennis players are more prone to subscapular denervation than other overhead sports athletes. It's important to include in shoulder MRI routine a sagittal image without fat suppression and a major slice including the scapular Y shape in order to better evaluation of muscle base. And that brings me to the end of my presentation. Thank you for your attention.
Thank you, Patrícia.
Okay, now I would like to introduce Kate Stevens, who is an associate professor of radiology and orthopedic surgery at Stanford in California, with a special interest in sports medicine and rheumatology. She's completed her training in England and came out to California in 2000 for a research fellowship, but she never left. The academic environment, great weather, and excellent Californian wine proved too tempting. Kate is passionate about medical education and has lectured and run courses at multiple international venues, as well as being active in musculoskeletal MRI research. On a personal note, Kate adopted my pandemic puppy that I fostered, and she's given him a loving home and unparalleled quality of life, which I only wish that I had. Today, she's going to show us a case on one of her favorite joints, which happens to be the elbow.
Thank you very much for the introduction. I'll just share my screen. So thank you for the kind introduction. I'm delighted to speak here today. I have nothing to disclose with regards to this presentation. So the case I want to present is a 19-year-old collegiate right-hand dominant baseball pitcher who presented with mechanical symptoms for the past 2 to 3 years and an inability to fully extend the elbow. So when we look at the plain radiographs, we can see that there's some bony spurring at the olecranon tip. We can also see a rounded ossicle projecting over the distal humerus. And when we look on the lateral image, you can see that the ossicle is posteriorly within the olecranon fossa. Patient underwent an MR examination. And here we can see there's fairly dramatic thickening of the proximal fibers of the ulnar collateral ligament. Again, as we go more posteriorly, we can see that there's also associated undersurface irregularity here compatible with partial tearing. As we go more posteriorly, we're now starting to see these joint bodies within the olecranon fossa. Again, you can see that there are more than one joint body here. And then we can see that there's some hypertrophic changes of the olecranon tip with a small amount of associated bony reactive change. On the axial images, again, we can appreciate these joint bodies within the olecranon fossa, as well as some associated synovitis. Again, we can see that there's more than one joint body in this location. And when we get to the posterior humero-ulnar joint, you can appreciate that there's some joint space narrowing here with small marginal osteophytes. When we look on the fluid sensitive sequence, we can see that there's some associated subchondral cystic change here. And again, you can see these marginal osteophytes. These are in close proximity to the ulnar nerve, which is of normal signal intensity. But we can see this fairly dramatic subchondral sclerosis along the posterior trochlea, as well as the olecranon process. On sagittal images, again, we can see these multiple joint bodies within the olecranon fossa, and there's associated synovitis. And we can also see these areas of subchondral sclerosis along the posterior humero-ulnar joint. When we look at the olecranon tip, again, here we can appreciate this extensive subchondral sclerosis. And when we look at the olecranon tip, you can see that there's a small amount of cortical irregularity with cystic change as well as bone marrow edema. So the patient underwent arthroscopy, and here we can see the trochlea, and here we can see the hypertrophied olecranon process, and we can see that there's a lot of synovitis within the olecranon fossa, and you can see this very large joint body sitting within the olecranon fossa. Here's another view, and again, we can appreciate this very large joint body, but you can also see all these additional joint bodies sitting there. They're multiple joint bodies. And so this is what they managed to get out of the posterior joint. So you can certainly see why this patient may have had inability to extend the elbow. So this is an example of valgus extension overload syndrome. And that's a condition that occurs in the elbow of overhead throwing athletes. It's traditionally been described in baseball pitchers, but can also occur in a number of other overhead sports, and those include water polo, tennis, and javelin throwing. It's got a very high incidence in professional baseball pitchers, with more than 30% being affected by valgus extension overload. And typically the patients present with a gradual onset of medial pain. It's very common to get associated ulnar nerve symptoms, and usually they complain that they're not able to throw the ball as fast or as long, and they may have a subjective feeling of instability. And it's quite often career threatening in these throwing athletes. So as we saw earlier, there are a number of phases to the throw, and this includes the wind-up phase, the early cocking phase, the late cocking and acceleration phases of throwing. And tremendous valgus forces act on the elbow during the late cocking and acceleration phases of throwing, and these can exceed the tensile strength of the ulnar collateral ligament, leading to micro tears. So there are three main components to valgus extension overload. The first of these is going to be medial tension overload, and that can result in injury to the ulnar collateral ligament, ulnar traction spurs, heterotopic ossification, ulnar neuropathy, and injury to the flexor pronator mass. Forces are also transmitted to the radiocapitellar joint, and the compression forces can result in osteochondral injury, joint bodies, as well as osteoarthritis. The final component of valgus extension overload syndrome is posteromedial shear, and that can result in posteromedial impingement, as we saw in our case with olecranon osteophytes, as well as olecranon stress fractures. So if we look at some examples of these, this is the elbow on the left of a 21-year-old male baseball pitcher, and you can see that there's very striking thickening of the proximal fibers of the ulnar collateral ligament. Contrast this with an age-matched control, and that we can see that they have a normal caliber of the ulnar collateral ligament. Here we have another baseball pitcher, 21-year-old, who presented with medial elbow pain, and we can see that there's some heterotopic ossification within the thickened fibers of the ulnar collateral ligament. And here we can see the corresponding radiograph showing rounded heterotopic ossification akin to the ossification we often see in lateral ankle sprains. Here's another baseball picture. This was a Major League Baseball picture, and we can see this very striking bone spur arising from the sublime tubercle of the ulna with associated bone marrow edema on the coronal T2 weighted image. And we can also see that this player has a full thickness tear of their ulnar collateral ligament. Lateral compressive forces can result in osteochondral injuries. And here we can see a large osteochondral defect along the anterior surface of the capitellum with associated subchondral cystic change. And if we look on an adjacent sagittal slice, you can actually see a small joint body within the humero-ulnar joint. And this player was a water polo player. Finally, posteromedial shear. This was an 18-year-old male quarterback. And here we can see that there's some sclerosis and irregularity at the tip of the olecranon process with corresponding subchondral cystic change on the fluid-sensitive sequence. And on the sagittal image here, we can see that there's some fragmentation of the olecranon tip. Again, we can appreciate that there's some striking subchondral sclerosis both within the posterior trochlea as well as the olecranon process. So what about children? So an increasing number of children are now participating in overhead throwing sports on a regular basis. And the injury patterns that develop in children differ from those in adults, particularly in skeletally immature skeleton. So in the pediatric population, the epiphyseal plates are 2 to 5 times weaker than the surrounding osseous structure, and this makes them particularly susceptible to overuse injuries. So in the pediatric population, medial tension overload can result in medial epicondylar apophysitis, avulsion of the medial epicondyle, as well as avulsive injuries of the ulnar collateral ligament and flexor tendon. Those lateral compressive forces can result in Panner's disease and osteochondritis dissecans. And finally, the posteromedial shear can result in olecranon apophysitis, as well as olecranon stress fractures and trochlear osteochondral defects. So let's look at some examples. So this was a 12-year-old male baseball pitcher with acute medial elbow pain on pitching. Here we can see that there's an irregular ossicle distal to the medial apophysis. And when we look on the fluid sensitive sequence, we see that there's a small avulsion fracture. with interposed fluid. And we can see in this example that the ulnar collateral ligament remains intact. Here we see another 12-year-old male baseball pitcher who presented with right medial elbow pain. We can see that there's some subtle irregularity of the medial epicondylophysis with mild adjacent sclerosis as well as cortical irregularity compatible with medial apophysitis. If you contrast this with the asymptomatic elbow, we can see that the physis is thin and has crisp margins. Here's a 16-year-old male right-hand dominant baseball pitcher who had chronic right lateral elbow pain with superimposed acute medial elbow pain after pitching. So we can see that there's lucency within the capitellum, as well as a punctate joint body within the radiocapitellar joint space. And we can also see this small bony spur along the sublime tubercle of the ulna. When we look on the fluid sensitive sequence, we can see that the ulnar collateral ligament is markedly thickened with intrinsic high signal as well as periligamentous edema compatible with a grade 2 sprain. And when we look on the sagittal image, we can see that there's an osteochondral lesion along the anterior capitellum with disruption of the overlying articular cartilage as well as the subchondral bone plate. And there's high T2 signal deep to that subchondral bone plate, indicating that this is an unstable lesion. So this is compatible with osteochondritis dissecans. Here's another patient, 15-year-old baseball pitcher who presented with right posterior elbow pain. We can see that there's widening and irregularity of the olecranon physis. And you can compare that with the same patient, his contralateral asymptomatic elbow, where we can see a normal physis, which is partially fused. The patient went on to have an MR, and again, we can see that there's irregularity of the olecranon physis with interposed fluid and adjacent cystic change, as well as extensive periphyseal edema compatible with olecranon apophysitis. So in conclusion, valgus extension overload is very common in overhead throwing athletes, and we have seen some adaptive changes that can occur at a very early age. There are three main components to valgus extension overload, and those are medial tension overload, lateral compressive forces, and posteromedial shear. And as we saw, there are differing patterns depending on age, with a higher frequency of apophyseal and stress injuries in adolescent athletes and an increased incidence of soft tissue injuries occurring in older athletes. Thank you very much. I'd be happy to answer any questions.
Thank you, Kate. I have the pleasure to introduce Dr. Atul Taneja. He's a practicing musculoskeletal radiologist at Hospital Israelita Albert Einstein and HCOR Teleimagem in São Paulo. He coordinates MRI courses and is an instructor of radiology at Faculdade Israelita Albert Einstein. He's also an associate editor for BMC Musculoskeletal Disorders, and he's a member of the International Skeletal Society. Please, Atul, take it away.
Thank you, Aline. Thank you, Hillary, for the invitation. It's a great pleasure to speak to the OCAD audience, and especially seeing so great friends from all around the world. So my case presentation, I'm actually going to present 4 short cases of the same entity, similar findings, so you guys can use your good photographic memory in such type of clinical setting. So the first case, a male patient, 47 years old with muscular rupture affecting the calf while he was skiing 20 days before. He came back with plantar foot pain and swollen extremity. And we can see here in sagittal images some edema and contrast enhancement affecting the flexor digitorum brevis muscle. And especially in the coronal T1 post-contrast image, we see some enhancement around the fascia of the quadratus plantaris muscle and the flexor digitorum brevis. There was a suspicion made for this case, and the subject underwent focused ultrasound screening of this area with Doppler. And one could see that the vessels were not compressible, especially the vein. and also without flow after Doppler color tool. And the second case, a male subject, 50 years old, with plantar foot pain, along with the similar findings. In this case, we could actually see two longitudinal structures without contrast enhancement on the resembling a vessel structure. When we see in the T1, there was a little bit high intensity sinal abnormality, T2 low sinal intensity affecting this area, and after contrast enhancement, we saw some muscle enhancement and the myofascial plane seen. Same thing. Focused ultrasound with Doppler to this region showed enlarged vessel with some content within it, without Doppler flow, and also not compressible. This coronal image after post-contrast, we could clearly see these two structures non-enhancing with perivascular, perivascular edema and muscle edema in this area with contrast enhancement. And let's move to the forefoot. In this third case, a female subject with 43 years old with pain below the second intermetatarsal region. One could see very quickly here and say, oh, there is a mortal neuron here, but pay attention. When we see this neurovascular region, there is a very bright sign intensity here. And after contrast enhancement, we see the wall enhancement of something which resembles also the venous anatomy, the venous structure, clearly seen in this long axis, contrast enhancing the vessel wall, and without, with some irregularity and heterogeneity affecting the content of this vessel. And the last case, also in the forefoot, now affecting the first toe, there was some pain below the neck and the head of the first toe, and similar findings with some muscle edema, edema affecting the myofascial plane, actually in the perivascular region. And when we see in the long axis, we could see this longitudinal structure with wall enhancement and some content in kind of a filling defect seen here in the MRI images. Easy. Who saw once, who saw twice, who saw 3 times can say it's a deep plantar thrombophlebitis. That's the diagnosis. But there are few studies about deep plantar thrombophlebitis. The pathogenesis is unclear. Most of them are related to previous surgery, trauma, paraneoplastic conditions, abnormalities affecting the blood coagulation, immobilization, and physical activities. It's a difficult diagnosis clinically because there is a wide range of differential diagnosis that may affect this area and also may mimic a lot of different pathologies in the plantar region. That goes since intermetatarsal bursitis, mortal neuroma, sesamoiditis, plantar fasciitis, tendon pathology, cyst, or stress fracture, which is very common. I would like to show some results of a small study we performed with 20 subjects that presented plantar foot pain, and these MRI findings were suggestive of thrombophlebitis. We had 14 males, 6 females, with a mean age of 46 years old. In a subset of 8 patients, we were able to confirm using ultrasound, but I would like to show the MRI findings that we can rely only on the MRI if needed to do this diagnosis. The parameters we evaluated were in pre-contrast images, the presence of perivascular edema, muscle edema, T1 and T2 weighted images, sinus intensity changes, venous dilatation, enlarged collateral vessels. And in post-contrast sequence, we looked for perivascular enhancement or intraluminal filling defect. First, let's review quickly the anatomy of the deep plantar venous plexus. Remember, there are multiple veins. They rely on the deep space of the foot below the plantar arch, and they are vulnerable to repetitive trauma. So we have the lateral plantar veins, medial plantar veins, plantar metatarsal veins, and plantar digital veins. We can use this section for segment anatomy. So in our cases, 32% of them, the thrombophlebitis affected the lateral plantar veins. In 8%, the medial plantar veins. 40% affected the plantar metatarsal veins, and in 20% of cases, it affected the plantar digital veins. Some of them affected more than one segment. That might happen also. And regarding the findings, 100% of the subjects presented perivascular edema on T2 images. And we can also say about perivascular edema after contrast enhancement. I'll show you a little bit later. Muscle edema, as we can see here, affecting the quadratus plantaris muscle, the flexor digitorum brevis muscle, and especially the myofascial plane between these both muscle structures. 100% of the cases presented changes in T2 sinus intensity, most of them intermediate to low sinus intensity, and 85% presented intermediate with high sinus intensity on T1 in 15% of the case. As you can see here, it depicts the presence of methemoglobin affecting the thrombus, the clots within the vessel, as we can clearly see here in this filling defect image. Venous dilatation was present in 85% of cases, as we see here, enlarged vessel with the thrombus within the luminal, within its lumen. Enlarged collateral was only present in one case, as we see here, very enlarged collaterals, very marked enlargement. Also, 100% of the cases, perivascular enhancement, as I presented with the perivascular edema, perivascular enhancement, some fatty tissue obliteration, also seen in this case. And also 100% of cases presented with the filling defect. And I would say that's the most reliable sign we can use to define this diagnosis of plantar thrombophlebitis. So in summary, MRI findings of deep plantar thrombophlebitis, we could rely on perivascular edema, perivascular enhancement, intraluminal filling defect. MRI shows to be useful to diagnose this kind of entity in patients with plantar foot pain. So remember about this differential diagnosis. Do not make the mistake to be confused about mortal neuroma or a muscle strain. If it is not so clear, use post-contrast sequences, and whenever it's possible, suggest a Doppler ultrasound, both to the diagnosis as a gold standard and also to the follow-up. So these are some references. As I said, there are some scarce material on that on the literature, and I invite you to follow my social media accounts. Thank you very much.
Thank you very much, Atul. We have some questions, a few questions from the audience. So the first one, I think it's related to Patrícia's case, and it's from Pablo Rengifo. He's asking, it is interesting that infraspinatus atrophy is asymptomatic most of the time, since some recent studies indicate that the infraspinatus is more important for abduction and external rotation of the shoulder than previously thought. Any thoughts on this?
Okay, interesting question. Indeed, infraspinatus muscle, it's very important external rotation. One explanation for this athletes don't have significant symptoms or changing their performance is because they use more the teres minor than the general population because of their intensive training. Maybe if infraspinatus atrophy occurs in an athlete's person without this kind of training, this person may suffer more for loss of the function than the high-level athletes. So as I said, it's very important to detect other signs in these athletes like paralabral cyst or there is minor atrophy, secondary accelerated denervation, because other muscles may make this function. But it's not 100%, but it's the explanation.
Thank you, Patrícia. There's another question from Paulo Noronha. I'd like to know if the speakers routinely use IV contrast in foot examinations, and if not, when you think it's indicated. I think it's related to Atul's case.
Paulo, very nice question. Actually, it's in most of the talks we give regarding foot entities, we have this question. So in the institutional work, we have a very strict protocol where we use contrast enhancement in all 4 foot images. I'm sorry, all 4 foot exams. So for the hind foot, there is not necessary. But for 4 foot, we have this using the contrast enhancement routinely. Okay, that's controversial because most of the institutions do not use contrast enhancement in all of the 4 foot cases. But we have seen, especially for not only for venous pathologies, but sometimes it helps to check for ligament tears and also for plantar plate tears. This is not a consensus, but we have been using routinely for 4 foot MR cases. But you cannot do that. I would say if you have a suspicion for a infection, inflammation, inflammatory articular changes, venous entities, tumors, then you should use the contrast enhancement.
Okay, thank you. There's a question from Hillary. Hillary, do you want to ask yourself?
I'm curious about the study you referenced with 20 cases of deep vein thrombosis in the foot. I've seen a few cases in practice, and they've all been pretty much in the midfoot region or hindfoot. And I don't recall, maybe I've seen one in the forefoot, but when I've reviewed the literature, I don't think those are common, and yet they were most prevalent in your series, which makes me wonder, was there a common history or maybe some sort of sports activity unique to Brazil that put your
yeah, I got it. Yeah,
distal forefoot?
Yeah. So I actually would like to use this time to thank my friend, my colleague Frederico Miranda, that gave me some cases. Actually, he's been collecting. He has around 40 cases by now of deep plantar vein thrombosis. Yeah, I agree with you. Most of them, most of the time, we do not think about this diagnosis. For the forefoot, especially, the cases were related either to soccer or jiu-jitsu, most of them. But again, there is not a specific sport related or
I think it is. I think it must be.
Yeah, yeah. But I mean, we've seen in many different sports, but as I remember, most of them are soccer or jiu-jitsu.
You should put it in the discussion because I think your distribution differs from the existing literature, and it's probably because of this. Yeah.
So for sure, we have presented these cases in a previous RSNA meeting, and the paper is on the way. The project is an ongoing project, and we have collected even more cases.
Excellent.
Okay, I don't see any more questions here. So thank you all for tuning in today. And we all look forward to the next session. See you next month. Bye-bye.